talking to Dr. Jesus Aranda. He is in our behavioral health team here, manages all of our LCSWs. He is a neuropsychologist. I'm gonna let him tell you guys a little bit about himself.
So, Jesus Aranda, and I'm originally from Spain. I came to the United States around 25 years ago, and I went back to school. I got my doctorate in psychology and specialized in forensics and neuropsychology. And I have worked in psychology for over 12 years now, and specialized also in dementia, traumatic brain injuries, head trauma, strokes.
And I guess one of the big things that you see all the time for us is the dementia patients. And that's one of the things I wanted to talk about today, because I think there's a lot of information when people find out that their family member has dementia. You can Google dementia and you tend to see all the neuroscience about it, but there's not a lot of layman's terms about dementia. So I think, first of all, I think a lot of people think of dementia as it's just dementia, but we know there's different types of dementia. So I wanted you to kind of talk about what you do to kind of figure out and help the families understand what type of dementia it is and what the differences are between the types of dementia.
Correct, that's a great question. So dementia is actually the functional decline because of the changes in the brain. So what causes dementia for the most part is Alzheimer's, which is called Alzheimer's dementia. But other causes that changes the brain could be vascular dementia, Lewy body's dementia, frontotemporal dementia, multiple types of dementia, and sometimes they're mixed. What we usually do from the neuropsychological standpoint is to do an exam of cognition. So we test for memory, we test for attention, for concentration, for visual spatial abilities, we test for intelligence, we also test for executive functioning, and the profile of the data that we get when we test the patient might determine in most of the time what type of dementia the person might have. For example, in Alzheimer's dementia, we see a significant drop in memory and recall and recognition of what the person is being told. In vascular dementia, for example, we see that the person might be slower to respond or slower to come out with words that are more significant in people with vascular dementia. One other dementia that is very, very common is Lewy body's dementia, that has aspects that could be vascular and Alzheimer's, but also have some features such as visual hallucinations, problem with sleep. So each dementia is particularly significant for some cognitive decline versus others, but they all have one thing in common, which is the decline in functioning.
Well, and I think it's important too that not all dementias are the same and they aren't all treated the same. So some medications tend to help more, such as I think a lot of people hear of Namenda or Aricept tends to be a neuroprotective agents that tend to be used in Alzheimer's dementia. And I think one of the other common terms we hear a lot of times for Alzheimer's is old-timers. A lot of people say that. Right. So that's sort of a synonym for Alzheimer's. The Lewy body tends to be the one too that we've seen a lot more aggressive behaviors. They tend to get really agitated very easily. But let's talk a little bit. I know one of the things that I love to use Dr. Aranda for is diagnosis clarification. Like he talked about being able to say what type of dementia is it. He also does a lot of capacity testing, and I know a lot of people out there, mom's starting to get forgetful, dad's starting to get forgetful. Why don't you talk a little bit about what that testing looks like? Like, what do you expect when somebody comes in for cognitive testing, and what are the results going to show? Will that say, hey, they need a guardian right now, or maybe that allows them to enact their power of attorney for finances or other things? So just talk a little bit about that and what to expect when you show up for the testing.
Correct. So the testing is cognitive testing. So like I said before, we're going to test for memory, we're going to test for functional abilities. let's say that somebody comes and they have an IQ of 110. So they have a master's degree, they have worked all their lives, and now they're not even able to pay bills or manage their own medications. That is the functional decline that we have seen because of the dementia. Then we test those capacities and we see there is a huge decline from what is expected for the person to have an IQ of 110, that now their memory is in the 70s or 80s. So we compare that decline. The functional abilities, like I said before, are the ones that are more obvious to the family members. So can the person make simple decisions? Yes, they can. They might have conversations. They might be able to think what they want to do on Sunday. But can they decide in some of the cases how to make complex decisions? That is very difficult. For example, paying bills, driving a car, making financial decisions such as buying a house, or even understanding their own protocols for medications, or if they're gonna do a surgery, do they really understand that they have to go through surgery and what are the pros and cons of the surgery? People with dementia might have in the late stages difficulties understanding complex procedures, and that's why we measure capacity. Some people with dementia will show diminished capacity to do certain things that they used to do before. So we help the families understand there is a decline in cognition that is affecting their function. And as they don't function as well as they did before, somebody has to make the decisions for them.
But one of the things, like, what should they expect when they show up? Is this testing 30 minutes? Is it 45 minutes? Is it all day? What kind of things do they need to expect when they come for it?
Yes. So usually the testing session, there's in the beginning, there's an interview session in which I interview the patient or the resident, and you can tell whether they're good historians, they're reliable historians, or they're confabulating in their history, especially people with Alzheimer's. They forget and they might say things that are not true, not that they're trying to lie, but they cannot remember the things that they used to do before.
And they try and fill in the blanks a lot of times
Right.
too. They know they need to give an answer, and so
Right.
they make up something that sounds feasible in their mind, whether it's true or not.
Correct. That's why it's also important to talk to family members to contrast that the information that the patient is giving versus what the family members might say. So when it comes to the testing might last in between an hour and a half and 3 hours. The problem at older age is the stamina, the energy, all these tasks that they have to do, remembering 10 words and repeating the 10 words and remembering 30 minutes later, and doing some tasks that are processing speed. You know, they have to give us words in 1 minute to see how the brain can look for words, because in dementia, as we know, some people start losing their ability to come up with words and word finding. So the testing time varies from person to person and for the type of the problem. If the person has Alzheimer's dementia to a moderate to severe level, probably the testing is not going to last as much as somebody has a mild cognitive impairment in which they have some decline but not enough to call it dementia. The person are going to do is going to do some testing with memory, is going to do some testing with processing speed. They're going to have to get up, they're going to have to move sometimes, they're going to have to take breaks. So it might take probably on average 2.5 to 3 hours.
Okay. And what, at the end of it, do they get a report? Do they get something that they take? Like if you explain to the family, do you sit down with them and explain, here's where we are, here's what the capacity is, and make recommendations as far as they need somebody else to help pay the bills, and what does the family get to take with them to enact?
Right.
Yeah.
So I do the interview with the family initially. I do the interview with the patient. I order the testing. And once I gather all the data, I produce a report. In the report, it's
So is that same day? Sorry to interrupt, but is that like the same day, or is it usually like a couple days later when you're doing the interpretation?
It might be. It'll be a couple of days later. So we do the interview one day, then we order the test probably another day or the same day. It depends on the time or the situation or the location of the patient. And then when I gather all the information, I write the report probably within a week or 2 weeks. And then I call the patient or I call the family members to give them feedback of the results. In the feedback of the results, I'm going to review all the information. I'm going to have my clinical impressions and my treatment plan and recommendations. Sometimes, if the dementia is severe, moderate to severe, I might recommend the family that they either get guardianship or that somebody makes decisions for dad or mom because they have diminished capacity to do so.
So one of the things you talked about earlier too was evaluating people who are driving. I think that's a big issue in our patient population as people get older. Driving is one of the things they tend to want to hold on to, even whenever we know their reaction times are slowed or we feel that they're dangerous. So talk about how that can be good for family members to bring to you for testing so that they have sort of solid evidence to be able to use for taking the keys away, so to speak.
Right. So safety is first. And like I always say in my recommendations, driving is dangerous. And driving is dangerous for somebody with diminished capacity to do so because they put themselves in risk and they put others at risk. So most of families agree when they come to us about driving that mom or dad might not be safe driving. So what I ask during the interview is, have they had any accidents? Are they hitting the curbs? Are they able to park the car inside the garage? And just by asking that, family members sometimes realize, oh, well, no, there's some diminished capacity there. And if the person then, through our testing, shows problems with working memory, show problems with remembering what they've been told, and their memory is not good enough, or their visual spatial abilities are quite diminished, it's good to think that driving might be very dangerous. I always tell the families that the act of driving might be the easiest way. It's an easy task. However, driving with others, reacting to the environment, stopping at the stop sign or at the traffic light, and being able to select and divide your attention in so many ways when you're driving might not be easy when they have dementia, and they might put themselves in danger because there's too many things that you have to be managing, especially in attention and memory when you're driving. And in dementia, attention and memory is usually diminished.
Yeah, and one of the other things that we do a lot of times in post-acute care in the facilities themselves, we're asked to do certificates of medical exam, which is a letter, basically a form that goes before a judge for the judge to make a decision on whether a person has capacity or not. So one of the things we do a lot of times is we coordinate where Dr. Aranda will do the testing and then give the results to the primary care physician, and then we'll make the recommendations of signing those certificates of medical exam. So it's a coordinated effort between primary care and behavioral health to get those to the judge for the proper recommendations to try and get court-appointed guardians for some of these residents who don't have family members or aren't capable of making decisions. And I think one of the big pushes right now is, for a long time, we've allowed patients with dementia to kind of go and go and go and go and go, especially if they were in a facility, a long-term nursing home. And what's now happening is they're good until they're not good. So they fall, they break a hip, they go to the hospital, and then the orthopedic surgeon saying, hey, they don't have the capacity to consent and understand the risk of the surgery. So now they can't get the surgery they need. Now they're no longer going to be able to walk, and there's a lot of implications. So I think the states are now government agencies are really pushing the facilities to say, if you know this person has diminished capacity, you really need to be seeking a guardian or somebody to make decisions, especially medical decisions for these people. Financial decisions, maybe not so much, just because a lot of them are on Medicaid and they only have a little bit of money coming in every month. But definitely for those who have estates, it's important to have guardians that are involved in that process. So tell us some of your funnier stories from when you've been doing testing. Like, what's a funny story of something a patient did during testing?
So, one thing you surprised me with that question. But one thing that I get a chuckle of sometimes with older folks, for an assessment of attention, I ask them to spell the word world forward, and they might say WORLD, and when I say spell it backwards, they start spelling the word backwards. They say BAC when I meant is just spell the word
world backwards. Yeah.
So those are the kind of what I remember right now. There's always funny stories when you say something like backwards and they turn the paper backwards instead of just saying do something backwards, like going from 10 to 1 when they have to draw lines. So that's all I can think of right now. Funny stories.
So one of the other things is that you also do testing in English and Spanish. Yeah. So is there a difference between the tests at all, or is it the same test just done in Spanish?
No, that's a great question. No, we have to be mindful of that. We have to use proper standardized norms closest to the population we're testing. So if somebody is from Mexico or from a Spanish country, and they were brought up and they went through their education in Spanish, we must test them in their primary language. There is few bilingual. There's sometimes the problem is gauging whether the person is more English than Spanish, because there are people who are bilingual. So my primary language, for example, is Spanish. So when I'm 85, somebody's going to test me. Please test me in Spanish because it's my primary language.
But you've learned it in English, so like you already know world backwards, so you could pass it. Like
right. And sometimes we have seen that people who are bilingual are more protected from the dementia part in terms of cognition because they know 2 languages. So if they don't know how to say the word ball, they can always say pelota in Spanish. So sometimes the losing of words does not occur as much on people who are bilingual. What I have seen sometimes is people who were perfectly bilingual 40 years ago, now they start losing their second language and they become their first language. The second language decline much faster than the first language.
But you see that, like, if they're in the U.S. speaking English most of the time, their English starts to digress, but their Spanish comes.
The Spanish comes more automatically, and it has to do with some areas of the brain in which the first language the brain learned was Spanish. Now you came to the United States, you learned English perfectly, you went to school in English, and all of a sudden you get dementia and your second language start declining much faster than the first language, and you go backwards into your first language, even though that one might be also decline. But in central physicians, we use English norms and Spanish norms. In the neuropsychological team, we use Spanish norms that are for the south of United States and the north of Mexico, which is our population. So we do a great job measuring the person who was born in Mexico with the norms from the Mexican and Spanish norms.
So what do you do for the patients from India or other like Vietnamese or things like that?
Right. The problem in neuropsychology is that there you have to use a translator. and you might not get the same sense or of their diminished capacity that you could get when the doctor or the tester is a person native of the language. So
I know for me personally, like I've had to use the translation phones before, and I don't know, it's probably just me, but especially with sort of the Vietnamese languages, it seems like you can ask a question like, does the patient have pain? And there's this huge conversation with the translator saying all kinds of stuff, and you see the patient answering, and they're like pointing and touching themselves and pointing to areas. So it's a back and forth kind of get up, and then you say, you wait, and there's a pause finally, and then the translator will say no. And you're like, really? Like,
right.
There was a whole conversation that I
Right,
missed right there. So,
yeah, that's why I think it's important to know your translators. Sometimes I prefer to have a translator than an interpreter, because if the person you're using is not accustomed to medical terms, they might just listen to the person and then just interpret for the person instead of just saying what the person has said. So like in forensics or in neuropsychology, it gets much more difficult because the translator has to be a certified translator that knows the medical terms and knows what to say, and it has to be kind of like the voice of the patient more than just the interpretation of what the patient is trying to say.
So literally translating exactly what
Right.
the words that they're
Right.
saying. So when do you think it's important to, or is it important to get a baseline reading on patients ever?
A baseline, a neurocognitive baseline?
Mm-hmm.
I think so. Once they have a complaint, once they have some complaint about, I'm losing my memory, I cannot come out with words, or I have a couple of accidents driving in the last 2 months, and the loved ones are saying, I think my mom is, usually they say, is losing it. I think it's good to have a baseline, because that way we can catch the disease in the earliest stages instead of just waiting, like you said, until the stages are so moderate or so severe that the person end up having an accident. We have to also remember that in dementia, there is something, the concept of pseudo-dementia. In the late stages of life, some older folks might get depressed or be very anxious about the future, what's going to happen to them. And they start having cognitive problems, but they might be intact cognitively. Mm-hmm. They're just suffering from the depression that looks like dementia because they're not remembering things. But that is not dementia, that is depression. So we can treat psychiatrically the depression, and then they can come out of that state, that fake state of dementia.
Okay. There's kind of two other things I wanted to touch on real quick. One is, so how does all this get paid for? How does that work? Because that's going to be one of the questions that people ask. So do they have to come in and pay? Is it insurance? Is it...
Neuropsychological testing is usually approved by all insurance, and especially Medicare and Medicaid. In the nursing homes, most of our patients are Medicaid, or the skills might be Medicare, and that gets paid. I don't have any experience in the nursing homes where somebody has to pay directly to us in that sense, to the doctors. I mean, that goes to the
insurance.
Insurance.
Yeah, it's a covered thing. So, and then one of the other things is you touched on hallucinations earlier. How common are auditory or visual hallucinations? So talk about that, because I think a lot of times when we talk about dementia, we don't always talk about all the kind of side effects or other symptoms that people have with that.
Right. So in the moderate stages of dementia, there's going to be a change in personality. Some people who were very calm during their lives, that become very anxious. Some others who were very anxious, they become very apathetic, and they become very mellow, and they change their behavior. But also remember that we're talking about the brain. So the brain are going to have symptoms, not also a diminished cognition, but they might have symptoms of, like we said, hallucinations, psychosis. Sometimes they're going to have distortion in their reality just because the brain is changing. This is not someone who is at the age of 85 developing schizophrenia. We might have the same symptoms. This is someone whose brain is diminishing, to sort of speak, and the person is going to have behaviors. We have to also remember that in geriatrics, folks are prone to infections much more easier, and especially UTIs. So when there is this phenomenon of delirium, the person becomes delirious, they're going to see things. Delirious and seeing things is much more common because there are visual hallucinations than the actual psychosis. In psychosis, we're gonna have folks experiencing more what we call auditory hallucinations, and they hear things that are not there, or they hear children in the hallways when there's no children in the hallways. Lewy body's dementia, that, like I mentioned before, one of the prominent features of Lewy body's dementia is visual hallucinations because of the problems that are in the area, in the posterior of the head, in the area of the Lewy bodies deposits those Lewy bodies, and then they might experience the visual hallucination as the visual centers are on the back of the head.
So one of the other things I think we see a lot of times in dementia, you talked about a little bit, that the personality can change. So a lot of times we hear from family members, my mom was so conservative and now she's like disrobing in the hallways and yelling out profanities and stuff.
Right.
And the family members get very disturbed by
Right.
all these behaviors.
Right.
So what is sort of some advice or what you talk to the families about when they're getting stressed about
Right.
what they're seeing?
And that is particularly common in one type of dementia. It's called frontotemporal dementia. In frontotemporal dementia, the main features are personality changes and lack of inhibition. As the person doesn't have those filters anymore because of the dementia in the front of the brain where the executive capacity is,
And personality, a lot of personality.
in personality changes, you're going to see that older folks with that type of dementia might start cursing, using foul language, disrobing, getting naked, hypersexuality too. The only way to deal with this is with medications. Try to recommend medications that might help that type of behaviors, because at that stage the person might not comprehend what we're trying to tell them. So it's important that the families reach out to the doctor so they can get an explanation on why my mom has changed so much and what's going on. If the families don't know why it's happening, it's hard for them to deal with that reality. But when it's put into words and we can have a conversation, and in neuropsychological assessment, we have conversations with the families all the time. I always say that I cannot do a neuropsychological exam for dementia without talking to someone for collateral information.
So any parting words of wisdom or anything you want to share with us about it, or encouraging family members to reach out earlier maybe than later in the dementia process, or starting to notice changes? And
Right.
yeah, and that's also something too, I think you can do as an outpatient too. You see people in our outpatient clinics. They don't have to be in a nursing home to come and see you. They can have the testing done as an outpatient. And probably a lot of people out there, how would they find a neuropsychologist in their area? Just kind of Google, or what do you suggest?
Yes, Googling or Psychology Today, neuropsychological assessment, or neuropsych assessment, or licensed psychologist, cognitive assessment, something like that. We are not too many here in San Antonio, so it's not, it's not difficult to find us in Century Physicians, and that's what I would do, a Google search or in Psychology Today.
Great. Well, thank you for coming and talking to us today. We're just trying to get a lot of information out there for everybody, trying to educate everybody about things that go on in the post-acute arena and being able to access information that you need to make those decisions for your parents, your loved ones, other ones involved in your life. So just pass this on to anybody who you know who might need some of this information, or might be looking or might be searching for information on what to do with somebody they have who's starting to get forgetful, or some steps that they can take. So thank you everybody for tuning in. We'll talk to you later. Thanks.
Thank you.